Yes, hi everyone. My name is Dr. Abubaker Al-Madani, neurologist in Rashid Hospital, United Arab Emirates. Our talk today will be on medication overuse headache. Okay, so our clients will be based on introduction of what do we mean by medication overuse headache, the epidemiology and incidence with prevalence worldwide, and somewhat in Rashid Hospital or UAE. The common question on medication overuse headache, is it a cause or a consequence? We're going to elaborate this more in our talk. Then we're going to go with the classification of medication overuse headache, common drugs causing headache, and treatment strategy at the end. So beginning with medication overuse headache, it had many names in the past. They used to call it rebound headache versus drug-induced headache, medication withdrawal headache, which was introduced by Matthew and Rappaport. So it had many names throughout the years, but the most common name which is used now is medication overuse headache. Why we need to know this? Because it's a very important risk factor for chronic daily headache, as per Capubiano in 1988. It is also headache which is very refractory to pharmacological and non-pharmacological treatment. So how do we define medication overuse headache? So if you're having a headache for more than 15 days per month, for more than 3 months, and you are over-consuming more than one medication, one acute or symptomatic medications, then you are at risk of developing medication overuse headache. And classically, the headache is usually developed or markedly worsened during medication overuse. Okay, so the rule of thumb here, if you are using triptans or ergot or opioids more than 10 days per month, you are fitting the criteria for medication overuse headache. Or you're using combination of these, you are at risk of having medication overuse headache. If you are using simple analgesics, such as triptans, ergot, or opioids, for more than 15 days per month, you are at risk of medication overuse headache. So we can tell here, the medications such as triptans, opioids, ergot, you need less amount of tablets or days to develop medication overuse headache. So what is the epidemiology of medication overuse headache? How common it is? Is it worthwhile to know about it? In Switzerland's study, which were conducted there, it turned out that 4.4% of men and 7% of female, they were using at least one type of analgesic once per week. So that's a big number here. So, and 2% of population use medication on daily basis. We're not talking about third world country. We're talking about country like Switzerland. 4% had chronic daily headache. Out of those 4%, 30% of them had medication overuse history. So that's significant history. So if you count it, that would be 1% headache. So the prevalence, which was conducted by Dudek in 2002, it turned out to be 1% of the whole population who are at risk of having medication overuse headache. Well, recently it was published in approximately 2017 or 18. It turned out that medication overuse headache is approximately 4% of whole population. The incidence of conversion from episodic to chronic migraine is 2.5%. So you are at risk of converging episodic migraine to chronic migraine if you are having medication overuse headache. In a study which were conducted in Germany, in neurology clinic, it turns out that 10% of the whole clinic population had medication overuse headache. And it was thought to be underestimated because of coding issues. In specialized pain clinic or headache clinic and tertiary center in the United States, it turned out to be 80% of clinic visitors were having medication overuse headache. So that's big numbers. It can run from 10 to 80%. There was a study which we conducted in Rashid Hospital. We found out that we see approximately 2,430 headache patients in Rashid Hospital. Among those, 240 patients are having or suffering from medication overuse or medication-induced headache. Well, the question is here whether the study is reliable or not. If we went to ask our colleagues whether you are really putting the cause, if you're suspecting medication overuse headache, it turned out that many of our colleagues were not putting the cause for medication overuse headache. So we are probably underestimating the numbers. But if you're seeing that if the number is true, then it's approximately 10% of the whole headache patient are suffering from medication overuse headache. So who are at risk of developing medication overuse headache? People with low education are certainly having greater risk for medication overuse headache because you need to have certain amount of education not to use those medicines every day. The common question, the patients come and tell you, doctor, I have headache every day. What do you want me to do? So if you're having patient with this attitude, they are at risk of having medication overuse headache. We found out as people with white race are at higher risk. People who had previous failed marriages at higher risk as well. If you are having caffeine abuse and obesity, so what we notice here, people who are doing bypass surgery to reduce weight, their migraine headache were getting, or their medication overuse headache were getting much better as well. So the chronicity, if you're having chronic migraine, you're more at risk of having medication overuse headache. If you're having other comorbidities such as diabetes or rheumatoid arthritis or other medication which encounter taking analgesics, you are at risk of having medication overuse headache. So what are the clinical presentation of medication overuse headache? Most commonly, people are having mixed type of headache. 2/3 of them are having neck pain. The headache could be unilateral or bilateral. It could be migraine headache or tension type headache. The classical thing of their headache is they have circadian pattern, meaning that they may get worse in early morning or they wake up from sleep with headache. They can also have autonomic symptoms along with their headache, such as tearing, injection of the eyes, redness of the eyes, and nasal discharges. Most of them, they have underlying depression or anxiety symptoms. Shifting the gear to the pathophysiology of medication overuse headache. So people who have medication overuse headache, they did PET scan for them, and they found most of them, they are having gray matter volume reduction in the gray matter area. So if you are having gray matter volume reduction, you are at risk of having medication overuse headache. So what happens with the repeated use of medications such as triptans, codeines, or narcotics, you're sensitizing the nociceptive receptors. and those are at risk of having more requirements of medication, and those go into a vicious circle. The common question is here: is the headache is causing medication overuse headache, or the medication overuse headache is causing the headache itself? So is it the chicken or the egg? That's what we are trying to negotiate or address. So people who believe that's a consequence, they are basing on this Norwegian trial, which included 32,000 patients between 84 and 85. Those people were taking medication for various causes of pain on weekly or daily basis. They followed them up 11 years later. They found out that they are at very high risk of having chronic pain. And among them, the highest risk was those who were having chronic migraine. They had 13%. Then comes the chronic non-migrainers, which is 6.6%, and neck pain, which is 2.4%. The limitation of this study is that we didn't know what kind of headache they had primarily before knowing the consequences. So those group believe that this is the medication overuse headache is the consequence rather than a cause. So those who believe that's a cause, that based on few studies, one of them is this study, which included 24 patients who underwent colorectal surgery. They observed headache in analgesic users. 19% of migraineurs developed chronic daily headache versus the non-migraineurs developed chronic headache only. So if you're having migraine headache and you're using medications, you're at risk of having medication overuse headache. So people who are using NSAID for other causes than headache, if you're having chronic daily headache, or specifically if you're having migraine, you're at risk of developing medication overuse headache, as opposed to if you're not having underlying chronic or primary headache. So some people still argued about it because chronic daily headache did not improve even with withdrawal of offending drug based on RELIA study in 2004. Some subjects reported also daily headache preceding medication overuse headache. And some population with medication overuse headache was not the most important risk factor for transformation of migraine. So those people believe that it's a consequence rather than a cause. So whether it's a consequence or the cause, the take-home message is here. Medication overuse headache is not the most important risk factor associated with migraine transformation, but we know that most of them have underlying migraine to begin with. Offending drug, and most of the time, should be withdrawn abruptly or slowly to reduce the headache or stop or eliminate the medication overuse headache. So definition: if you are consuming acute medication beyond the critical dose, and if you're having headache on more than days than not, and secondary causes are excluded, those patients are usually defined as medication overuse headache. So how many days you require if you are and you're at risk of having medication overuse headache? If for cases of ergot or triptans, if you're using medication, those medication more than 10 days, you're at risk of having it. If you're using other analgesics, then you're requiring only 15 days. Versus opioids, you're requiring maybe 8 days to develop the medication overuse headache. And if you're using barbiturates, you just need to use it for 5 days to develop medication overuse headache. So if you're using combination of those, you need more than 10 days to develop medication overuse headache. So overall, you can say between 10 to 15 days, and unless if you are overusing barbiturates, then you need only 5 days to develop medication overuse headache. So what medicines are mostly associated with medication overuse headache? The most common medication which is attributed to medication overuse headache, is barbiturate, and it is approximately 39.3% or 39.9%. The simple analgesic comes at the same percentage as with barbiturate, which is 39.5%. The triptans and ergot are more associated with less percentage compared to the barbiturate and other simple analgesics. So what times you need to develop medication overuse headache? On average, it's 5 years. Ironically, you need shorter time to develop medication overuse headache with triptans and ergot versus other medications. So if you're using triptans, make sure that the patient is not using it unless it's required, because they very rapidly and quickly they may develop medication overuse headache compared to other medication. If you're withdrawing the medication, though, triptan requires less time to abort the headache. So for triptans, you're requiring less years to develop medication overuse headache, and you're requiring less time or shorter time to abort the medication overuse headache if you are withdrawing the medication. So prevention, the main core for prevention is to reduce consumption of breakthrough medication. Using migraine-specific medication is usually favored. So if you're using one medicine which is tackling the migraine headache, such as triptans, it's better to use one tablet to abort the headache than using 5 tablets of NSAID, for example, to abort the headache. So specific and abortive medication will probably is required for those patients because they probably need less and less medication to abort their headache. And rule of thumb, not using the medications more than 10 days, and you probably may associate it or combine it with prophylaxis along with it. So the main core of treatment, or main pillars of treatment, is 100% weaning off of the overuse medication over the time. Concomitant usage of preventive medication or non-medical treatment along with bridging treatment. Limited use of acute medication, and rule of thumb, not using more than 10 days per month. Education to avoid medication overuse headache from day one when you see the patient and when you start the treatment for those patients. So the 4 main pillars for weaning of the treatment is slow wean or outpatient quick discontinuation of the medication. Those protocol can be done as outpatient, and that can enroll patients who are using, for example, triptans or NSAIDs. But if you are using more heavy medication, then you may need to admit the patient as inpatient. And at the same time, using preventive medication, you can bridge it with IV treatment along with slow weaning of medication or rapid weaning of the medication. You may require multidisciplinary team with it, or you may do it solely in one team. The studies showed either or. You choose either or methods, the outcome is more or less the same. So it's a very good outcome in 1 year time. So which patient are candidate for outpatient setting? Those who understand the concept of medication overuse headache, those people who are motivated, are very and very keen to stop the medication on defending medicine. Those patients who are not having underlying psychiatric illness, they have good family support, and they understand that they are not, and they are initially worsening before they improve. So they understand that their headache may get worse initially, then they get better, and they are willing to tolerate this. You can try this as outpatient. So what are the management approaches? You can use multiple models. The model which I choose in this talk is If you are using butalbital, for example, you can use gradual tapering or abrupt tapering, and you can bridge it with long-acting triptans or long-acting NSAIDs or tapering dose of steroid, along with acute treatment with triptans or NSAID. In case of opioids, you can choose gradual tapering. Usually, I use gradual tapering rather than abrupt tapering. If you choose to do abrupt tapering with opioids, then you need to admit the patient sometime. And you can use bridging treatment and acute treatment at the same time. And the same thing with triptans and NSAID. You can use either abrupt or gradual treatment based on the previous model, which I mentioned over here. So what kind of bridging treatment do you have here? We have many other bridging treatments, such as long-standing NSAID, COX inhibitors. You can use IV valproate for a few days. You can even use ergot, 2 milligram, 3 times a day as an example for 3 days, along with triptans. You cannot combine ergot with triptans, of course. You can also choose magnesium and lidocaine IV. Those are all of them are short-term treatment, bridging treatment. You can use it from 3 to 7 days. You can always use tapering steroid dose along with it. Clonidine, diazepam, tricyclic antidepressants, especially in opiate abusers, to dampen the withdrawal symptoms. You can also use neuroleptics such as metoclopramide for short-term as a bridging treatment for having the effect of the prophylactic treatment. What kind of prophylactic medication you use? You can use topiramate or conventional ones such as topiramate, propranolol, or amitriptyline. We recently can use drugs such as botulinum toxin along with it, occipital nerve blocks, phenylpalatine ganglion block, and recently with the new medications such as CGRP antagonists. We can skip this one because we already discussed it. So what is the overall prognosis of medication overuse headache if you are implementing the previously mentioned protocol for weaning, either rapid weaning or abrupt weaning, or gradual weaning, I mean. So the overall prognosis is 69%, 69.7% have good response after 1 year in detoxified group compared to non-detoxified. They reduce the duration of the headache by 60%. They can also, 70% of them may return to episodic migraine. So with good response, what do we mean by? We mean by at least 50% headache reduction. So and 73% of them, they have decrease in frequency of headache. The studies show to be better if you're combining with education. So it means if you're having multidisciplinary team service, you will probably have better outcome. So in summary, medication overuse headache is very common. It can be reached up to 1 to 4% of the whole population. Migraineurs should always be warned for risk of medication overuse headache in the beginning, in the first visit. Pathophysiology, which is worthwhile to mention, is that they have gray matter volume atrophy. We have plethora of treatment protocols, and none of them are superior to others. Thank you very much, and have a nice day.